Pointer. Good afternoon, everybody. I'm Dr. Mounika. I'm a consultant pediatric nephrologist from KIMS Cuddles, Hyderabad. So today I will be talking about congenital abnormalities of the kidney and the urinary tract, which we dearly call as CAKUT abnormalities. So coming to the introduction, usually the congenital abnormalities of the kidneys and the urinary tract, they occur in 3 to 6% of the live births, and also occur for 30% of the cases which progress to end-stage renal disease in Indian children. There is an interesting study done by our colleagues at JIPMER, Pondicherry in 2019, which has given us an Indian case scenarios and their occurrence in the statistics of CAKUT in our Indian population. So here, when they see the most common form of CAKUT is primary VUR, which occurs in Indian children, that is around 28%. And coming to the obstructive pathology like PUJO, that occurs into 20%. And next most common thing which we see is multicystic dysplastic kidney, MCDK kidney in 16% of the cases, and non-obstructing hydronephrosis in 10% of the cases. So they primary VUR, or they do not even have a obstructive pathology and still persistent to have hydronephrosis, which do not cause any end-stage renal disease or any renal injury. They occur in around 10% of the cases. And the surgeon's favorite posterior urethral valve occurs in around 7.5% of the cases. Around 6% of the children are born with a solitary kidney, and 6.1% of the cases are formed with cross-fused ectopic kidneys. It could be ectopic or a cross-fused ectopic kidney also. Both come in this category. So a hypoplastic or dysplastic kidney is very rare, that occurs only in 1% of the cases. The duplex collecting system is also a rare phenomenon which occurs in 0.5% of the cases. And the rarest of rare, which generally we see, is a vesicoureteric junction obstruction, as per the studies in the Indian population. So before we go into the understanding of different, we really have to understand the embryology development of the kidney, nephrons, and the urinary tract to understand where is the defect occurring, because of which we are landing up in such an abnormality. So the urinary system develops as early as 4th week of intrauterine life. So the embryo is divided into mesoderm, ectoderm, and the endoderm. So the mesoderm here, the mesoderm in the pink part is in turn divided into paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm. So the intermediate mesoderm has this forms a cylindrical structure which is called as urogenital ridge, which runs parallel to the future vertebral column. Along with that forms the nephrogenic cord, which develops into the urinary structures. So this nephrogenic cord in turn runs from craniocaudal direction. So in the 4th week, as the earliest of 4th week, this nephrogenic cord is divided into pronephros. That is, there is a which occurs near the head, near the neck region of the embryo. This is called pronephros. It develops in the 4th week. This pronephros is divided into nephrogenic ducts and nephratomes. This gets divided from the duct. So this nephrotome are the finger-like projections from the pronephric ducts which form. So this does not produce any urine, and this degenerates by the end of 4th week. And this pronephric duct then develops extends into the mesonephric duct or the mesonephros. So this mesonephric duct, this mesonephros also creates finger-like projections which are called as mesonephric duct, and the mesonephric tubules. This mesonephric tubules have a finger-like projections in the end, which represent the Bowman's capsule. This mesonephric ducts has a finger-like projections and has a like feature which resembles the Bowman's capsule. And this mesonephros directly joins into the cloaca. So the cloaca in the caudal end, from where the genitourinary structures and the GI structures develop. So here the metanephros, here the mesonephros we have discussed about, and this extends into the metanephros. So at the end of 5th week, so the mesonephros here, it disappears by 10th week. Up to 10th week, this mesonephros is responsible for filtration and urine production. So a clump of capillaries are formed at the Bowman's capsule-like structure, which we are seeing here. They extract the liquid fluid from these capsules and form urine and drain into the cloaca. They work from 4 weeks to 10 weeks of the time. During this time, there is also development of the metanephros. So at one point, the mesonephros and the metanephros both exist at the similar phase. So here at the metanephros, we see that there is a metanephric blastoma, which is from the intermediate mesoderm. So the metanephric duct form at the metaneph. So this this mesonephric blastoma, it stimulates and produces growth factors, which causes the development of ureteric stalk and a ureteric bud from the metanephrons. So this in turn, and this finger-like projection also produce growth-like factors, which in turn help in the growth of the metanephric blastoma, which in turn form into the kidney. So this is called as mutual stimulation. So as we have seen, this is the mesonephric. This is called the metanephric blastoma, which slowly grows and engulfs into the stalk-like structure. So the stalk, the tubular bud, in turn divides from 6 weeks to 8 weeks to grow into renal pelvis, major calyces, minor calyces, and the collecting tubules. So in the 8th week, that is the functional unit of kidney, which is the nephron, starts producing. So up to 10 weeks, the metanephros, up to 10 weeks, the mesonephros produce the urine. But after 10 weeks, the nephron takes over and starts the urine production. So here what happens, there is finger-like projection in the collecting ducts. From the collecting ducts, there is a S-like structure which forms and then extends to form the distal convoluted tubule, loop of Henle, proximal convoluted tubule, and the Bowman's capsule. And into the glomeruli, we have capillaries from the abdominal aorta, which which helps to formation of the glomerulus and the nephron. So from 6 to 9 weeks, we see that there is from 6 to 9 weeks, we see the vascularization of the kidney is done by the common iliac arteries. But after that, there is after 10 weeks, there is an ascent of the kidneys which start taking place. So then the abdominal aorta divides and forms the renal vasculature. We see the renal artery formation here, which then start vascularization of the kidney, and blood supply to the kidneys formed from the renal vessels. So this and we'll go back a little more. So coming to the genital urinary tract, how is it formed? So around 5th week, we have seen now the kidneys are formed, the nephrons are formed. So if you go back at the during the formation of the nephrons, there is also another event which is taking place. That is, there is formation of the bladder also. So here in the cloaca, we see there is a ridge formation which is called as the urorectal septum at 5 weeks. So this urorectal septum divides cloaca into the anterior bladder and the posterior anal region, which later develops into the digestive tract. So here we see the the mesonephric duct, which drains into the genitourinary cloaca. So here the urorectal septum forms, deepens, and forms the urogenital sinus. So, and the anal canal, which we have already spoken about. This is nothing but the the mesonephric duct, which you initially produce. We remember the middle part of the tract, the nephrogenic tract. So that is the mesonephrons, which was producing the urine initially, that used to drain into the bladder. So the urogenital sinus, the upper part forms the primitive bladder, whereas the mesonephric duct, which was draining, gets absorbed into the bladder during 6th to 10th week and forms the trigone of the bladder. So if you see carefully, the bladder is formed from the cloaca, but the trigone of the bladder is formed from the mesonephric duct. So this is the brief recap. So there is a urogenital rich from urogenital nephrogenic urogenital rich, from which there occurs the nephrogenic cord. This nephrogenic cord is divided into pronephros, mesonephros, and metanephros. The pronephros does not produce any urine and it completely disappears by the end of 4th week. The mesonephros produces urine till the metanephros takes over, that up to 10 weeks of life. And this mesonephros is absorbed to form the trigone of the bladder. The mesonephric duct, which drains into the cloaca, forms the trigone of the bladder. From the metanephrons forms the mature kidneys. So the urogenital sinus forms most of the bladder and the urethra. So from the metanephrons, forms the ureters and the collecting system, and the metanephric mesoderm forms the nephrons. So coming to the classification of CAKUT, there are abnormalities of the kidney, that is renal agenesis, renal dysgenesis, or dysplasia or hypoplasia, renal cystic abnormalities like multicystic dysplastic kidney, autosomal recessive dysplastic kidney, polycystic kidney, autosomal dominant polycystic kidney, renal ectopy, and horseshoe kidney. So coming to the abnormalities of the renal pelvis and the ureters, we have PUJ obstruction, that is pelvic-ureteric junction obstruction of the ureters, or extrarenal pelvis. Coming to the abnormalities of the ureters, we have vesicoureteric junction obstruction, vesicoureteric reflux, we have duplicating system, ureterocele, ectopic ureters, and rectocaval ureters. Coming to the abnormalities of the bladder, we have bladder extrophy, or a prune belly, or which occurs as a part of prune belly syndrome. We have bladder diverticulums also. So coming to the abnormalities of the urethra, we have posterior urethral valve, which occurs in males, hypospadiasis and epispadiasis. So first we will talk about the kidney, the abnormalities of the kidney. Renal agenesis or renal hypoplasia, it unilateral occurrence that can occur in one, that is a child born with solitary kidney, can occur in 1:2000 to 1:800, as common as 1:800. But bilateral is very, very rare, that is 1:5000. So if it occurs bilaterally, the child has in utero renal failure, and they end up, these children end up in severe renal insufficiency and do not progress to term. So if the bilateral, we see that there is renal insufficiency, we see there are called as Potter's sequelae. Potter's sequelae, low ears, beaked nose, prominent epicanthic fold and downward slant of the eyes, pulmonary hypoplasia and causing respiratory failure, rim abnormalities, and the skin abnormalities also. Because there is bilateral renal agenesis or bilateral multicystic dysplastic kidney, there is severely reduced fetal urine excretion, which causes oligohydramnias and fetal compression against the uterine wall. So these are the list of malformations or the syndromes in which we see there is a hypoplastic or dysplastic kidneys. We see there is agile syndrome where there is multicystic dysplastic kidneys, and mesangial lipidosis. There is Bardet Biedl syndrome where there is renal dysplasia, brachio-otorenal syndrome with renal agenesis. There is Chart syndrome, Dijot syndrome. There is hypothyroidism, HDR, hypothyroidism, renal abnormalities and deafness. And there is Fanconi's anemia and Fraser syndrome also. These are few more lists continues, which we see there is renal dysplasia, renal abnormalities in syndromic children. The common chromosomal abnormalities which we see in the urinary tract are trisomy 13, trisomy 7, Miller-Dieker syndrome 17p deletion, Edwards syndrome trisomy 18, Down syndrome trisomy 21, Turner syndrome. We see the common with renal manifestations. So come to the multicystic dysplastic kidney. Incidence is 1 in 3,600 to 1 in 4,800 numbers. So here we see that there is failure of the ureteric. We see in the development that there is I think everybody can hear me now. I'm sorry, I think there is some issue. Just a second. ఎక్కడికి వెళ్ళిపోయారు ఇది షేరింగ్ ఆగిపోయింది ఇప్పుడు చూడండి Sorry, I will start from the multicystic dysplastic kidney. So here, initially during the incidence is 1 in 3,600 live births to 1 in 4,300 live births. So initially we have seen that there is the metanephros, from which there is a stalk-like structure which occurs, which forms the tubules of the ureter. And from that is what we have seen earlier during the development. But here what happens is there is the differentiation of the stalk and the tubular mesonephric tubules fail, because of which there is a kidney formation because of the intermediate mesoderm from the metablastoma, but there is no collecting ducts or the tubules which form, because of which there is multicystic dysplastic kidney which occurs. There are multiple genetic factors and maternal drugs like AC inhibitors or cocaine or some papillorenal syndromes which causes a multicystic dysplastic kidney. Here the ureters fail to form and form the ducts. So there is a blood flow blood flow to the mesonephric duct, but there is but there is no proper glomeruli or the tubular formation. So coming to the polycystic, multicystic dysplastic kidney usually are unilateral. If they occur bilaterally, we see that there is severe Potter sequelae which occurs. But most of the cases with multicystic dysplastic kidneys, they tend to do well with a single solitary kidney, which works very well. But we have to rule out if there is any underlying vesicoureteric reflux in the healthy kidney, or how is the growth of the healthy kidney. But there is also a risk of development of Wilms tumor in MCDK kidneys that we have to follow up and monitor. So coming to the polycystic kidney diseases, so we have autosomal recessive polycystic kidney disease, that is ARPKD. This occurs because of the defect in PKHT1, which codes for fibrocystin. So there is no fibrocystin production, because of which there is dilatation, cystic dilatation of the collecting ducts in both the kidneys. Cystic collecting ducts in both the kidneys. This polycystic kidney disease is very common cause of death because of the because it occurs early in the development of the kidneys and cause severe pulmonary hypoplasia because of the severe renal insufficiency. Even though they cause Potter sequelae, if not, they progress into renal failure and systemic hypertension. So the liver also, in liver manifestations are also seen in ARPKD. They cause congenital hepatic fibrosis and portal hypertension. So in such cases, we see antenatally enlarged kidneys, oligohydramnias with cystic features of the kidneys in antenatal period with oligohydramnias. In MCDK, in multicystic dysplastic kidney also occurs antenatally, but it is unilateral, may or may not present with oligohydramnias if the one single kidney is functioning well, but the size of MCDK kidneys are usually small. So that is how we differentiate antenatally. In ARPKD, the liver involvement can occur in antenatal period or immediately in the infancy period also. These children usually tend to develop renal failure, and they require combined liver and kidney transplant. So coming to the ectopic kidney, so usually, as we have seen, the kidneys ascend into the abdomen, that is into their primary location during the somatic growth of the body. It is not the kidney ascending, it is the body which is growing, which forms the kidneys to move up. Here, sometimes there is failure of the ascent, which causes ectopic kidneys or the pelvic kidneys. Sometimes because of the twisting of the ureter or twisting of the embryo during the descent or during the formation itself causes cross-fused ectopic kidneys. So the incidence is 1 in 900 to 1,000 live births. They are prone to have vesicoureteric reflux because of the abnormal drainage into the bladder, the abnormal angular drainage into the bladder, or sometimes may have hydronephrosis or obstructive pathology also. So coming to the horseshoe kidney, these kidneys are horseshoe kidneys are the kidneys which you fuse. Both the kidneys, the lower poles fuse during the fetal development, causing the fibrous isthmus. They may be fused because of the development of the flexion or the development of the spine, and this kidneys sometimes move up but are usually lower than the regularly occurring kidney because of the abdominal aorta, and its branches. So sometimes it could be because of no reason, or it could be because of some chromosomal aneuploidy syndromes like Turner's, chromosomal 13, 18, and 21, or teratogenic drugs like alcohol and thalidomide. The incidence is very common, 1 in 4,000 live births, unless we, usually they are asymptomatic. They sometimes present with obstructive, PUJ, that is a ureteric obstruction, or sometimes may have vesicoureteric reflux. So because of the inferior mesenteric artery, they do not migrate up, so they are little lower than the regularly occurring kidneys, which the regular kidneys. So these horseshoe kidneys have increased risk of UTIs and the renal calculi because of the urinary stasis. And as I have already told there could be obstructive pathology also. So coming to the ureteric abnormalities, that is the PUJ, pelvic-ureteric junction obstruction. They are asymptomatic in infancy, but as the obstruction increases and the size of the anteroposterior diameter increases, there may be pain abdomen, feeling like a lump while mother is giving birth, or recurrent UTIs. UTI can also be a presentation. So we require ultrasound to see the kidney size, APD diameters, parenchymal thinning, and corticomedullary differentiation if we have found out the PUJ obstruction occurring later in the age, like it is occurred in the infancy period, but we have not identified or diagnosed, but presented at a later age of at an older age, then corticomedullary differentiation, because obstructive renal failure can occur because of PUJ obstruction. So ideally, we have to do a EC renogram with a ureteric window to see the drainage. And the pattern of the uptake. So with the EC scan, we can see the uptake of the dye through the filters to see, it will give us the idea of how the filters are working, that is the nephrons are working, along with the drainage pattern, which will give us an obstructive pathology or failure of drainage in the EC renogram, which is the diagnostic, the gold standard test, after which is indicated, like surgery is indicated if we have diagnosed. So indication of surgery is the split function is less than 40%. The APT diameter is more than 20%. There is recurrent breakthrough UTI despite antibiotic prophylaxis. But ideally, surgery is the ultimate and the best option for PUJ obstruction relief, because of which the kidney will bounce back to function into its normalcy. So coming to the VUJ or vesicoureteric reflux, so there is Mickey-Stevens law, that is the original ureteric butt arises at the irregular position of the metanephric duct. So that is the intravesicular submucosal enlargement of the is prime. So we see that the ureter does not just come and attach in the trigone. There is a good length of submucosal intravesical submucosal length of the ureter, which is the determining factor for occurrence of VUR. That is in the submucosa, in the bladder submucosa. We see this is the bladder submucosa. So the good length of ureter runs and then attaches at the trigone. If the length is shortened, that is where we see that there is occurrence of vesicoureteric reflux, or if there is obstruction also occurs at this point. As I have told, the intravascular submucosal and running of the ureter is primarily responsible for the anti-reflux mechanism. So coming to the vesicoureteric reflux, has very strong inheritance pattern, 25% risk in siblings, 25 to 50% risk of reflux in offsprings, and it is usually VUR is unusual in normal children. 20 to 40% of risk of VUR in children with UTI, and 40 to 50% of VUR in neonates with UTI. So the if a child comes with a neonate comes with culture positive UTI or symptomatic UTI, the risk of vesicoureteric reflux is very, very high. That is why it is quite important to evaluate any neonate with urine infection, a significant urine infection. So coming to the collecting duplex collecting system, that is the duplex ureters. That is because there is the ureteric bud which occurs from the metanephros usually arises twice, or there is splitting of the mesonephric duct. Splitting of the ureteric bud which occurs from the mesonephric duct. So it can be of multiple varieties. It can have a bifid renal pelvis which drains into a single ureter, or it can have a partial ureteric duplication, that is two ureters run halfway and then forms a Y-shaped ureter which enters into the bladder, or there are it runs to almost most of the area, and just before entering into the bladder they fuse to form one ureter, that is V-shaped ureter. That is the incomplete uretral duplication, or complete uretral duplication where there are two ureters running a long way and joining at two different points. So it is highly associated with uretrocele and vesicoureteric reflux. The incidence ranges from 0.8 to 5%. So there is a Wright-Meyer's law which occurs. That is the so when there are two, when there is a duplex system, we call it as moieties, the upper moiety and the lower moiety. So the upper pole or the upper moiety, the ureter from the upper moiety comes and attaches at the lower end. In the when there is an attachment, it does not occur upper, at the lower than the lower than the lower than where it enters into the bladder than the lower moiety. That is the upper moiety attaches below, where the lower moiety attaches into the bladder on the upper end. So in a complete ureteric duplication, the ureter whose orifice is more medial and caudal reaches the upper moiety, and the other ureter whose orifice is more lateral or cephalic reaches the lower moiety. So the uretrocele is nothing but outpoaching of the distal urethra into the urinary bladder. This is the uretrocele. They sometimes cause VUG obstruction. They can present as VUG obstruction, that is obstructive pathology, and they cause hydronephrosis and recurrent urinary tract infection. So cystoscopy and deroofing of the uretrocele is the treatment, and sometimes requires ureteric reimplantation also. So coming to the ectopic ureters, that is nothing but the ureter, instead of attaching at the trigone of the bladder, directly attaches into the urethra. So here there is, we see there is continuous dribbling of urine. There is recurrent urinary tract infection. There is also reflux in the ectopic ureter. So the treatment is ureterostomy, ureteric reimplantation. If there is a partial nephrectomy in case of non-functioning kidney, or ureteropyloplasty. So coming to the bladder extrophy, it is a rare disorder, but a complex disorder in which the abdominal wall does not fully form, leaving the pubic bones to separate and the bladder exposed to the outside of the skin surface through an opening at the lower abdominal wall. The occurrence is 1 in 50,000 live births. Treatment is surgically repairing, because here the main important is the compliance of the bladder should be maintained. So that has to be achieved, and that is the target for the surgery also, and to preserve the normal renal function and appearance of the normal appearance of the external genitalia and the functionality of the external genitalia. So coming to the posterior urethral valve, it is the most common cause of lower urinary tract obstruction in male children. The incidence is very common as 1 in 5,000 live births. So the histological changes leading to PUB start as early as 4th week, where there is a genital septum which forms at the cloaca, which causes the separation of bladder and the anal. anus. So there are three types of PUV. That is, type 1 is the most common, which folds originate from the distal edge of the colliculus. Type 2 and type 3. Type 3 is the most, the type 3 is the one with the worst prognosis because it is a membranous, it is a membrane which causes almost complete obstruction with just a central hole, and it is not linked with the colliculus. So this is the Young's classification. That is the most common type is the type 1, type 2 and type 3. That is a membranous type with the, because here the urine outlet obstruction is very, very severe, because of which there is a backward transfer of the pressure into the renal system, which causes the pop of valve mechanism, like that one kidney undergoes sacrifices, causing severe hydrourethral nephrosis, loss of kidney function. Because PUV occurs early in the development, there is also hypoplastic development of kidneys in both the kidneys, because the kidneys are developed in a very, very high pressure system. So usually what we do, we see the fetal urinary biochemistry levels, that is the amniotic fluid levels, which gives us satisfactory levels. So the sodium in the amniotic fluid should be less than 100 MEq. Chloride should be less than 90 MEq. Osmolality less than 210 milliosmoles. Urine output should be more than 2 ml per kg per hour, and beta 2 microglobulin should be less than 6 milligram per deciliter. So this gives us that the kidneys are functioning well. If you do the amniotic fluid, other than the urine output, the rest all parameters to be seen in the amniotic fluid, which will give us a clue saying that the renal functions are good and the kidneys are salvageable later in the life postnatally. Thank you.